please,
UK.
was
Thank you for inviting me to speak to you
okay.
today on this fascinating and controversial
So,
area.
okay,
I wanted to think about this diagnosis from the perspective of old age psychiatry, and in preparing for this talk, I was immediately struck by a couple of things: the lack of research into DID in general, and the lack of research into DID across the lifespans, especially in old age. So this presentation will be focusing on questions for discussion, debate, and future research. Firstly, is DID a problem for older adults? If we think it is, would we recognise it in the older adult? Then we will think about psychological considerations and theories when it comes to ageing in general. How can we anticipate that these may manifest in DID? And are any of the biopsychosocial challenges experienced by the older adult likely to be magnified in DID? Then at the end of the presentation, there should be time for discussion on all these points. So my colleagues, Dr. Ryrie and Assistant Professor Ekoli, have already given a comprehensive overview of DID, but let's have a brief reminder so we can begin reframing this information in the context of the older adult. Dissociative identity disorder, DID, is a term for this condition that was adopted in 1994 by the DSM-4. Prior to this, the condition was problematically known as multiple personality disorder. Research suggests that DID patients are typically diagnosed between the ages of 28 to 35, with the prevalence of this disorder estimated between 0.01 and 1% in the general population, and between 1 and 5% in clinical populations. Debate exists as to whether DID is a culture-bound syndrome due to the apparent higher prevalence in Western populations, but evidence of the condition can be found worldwide. So although not culture-bound, it is still important to consider cultural context as a modifier of the childhood trauma experienced, as well as a modifier of the expression of the disorder. The worldwide prevalence of this disorder gives weight to the view that this disorder is not specific to a certain generation, and therefore similarly likely to have occurred in those born 80 years ago compared to children born today. Although we have seen that the research suggests that the prevalence of DID is not wholly different to many other mental health diagnoses, it is nonetheless perceived by much of the general and professional population as far rarer. This in part is explained by DID being often a covert disorder, with only a small minority of patients, around 6%, having outwardly apparent disorder on an ongoing basis. In 1991, Kluft presented the idea of windows of visibility in DID, where opportunities for appropriate diagnosis and treatment exist across the individual's lifespan. However, research as to the incidence and prevalence of DID across the lifespan is limited. But we can hypothesize that DID, when considered as a disorder rooted in overwhelming childhood trauma, alongside disturbed attachment, resulting in a disruption of the development of a cohesive sense of self, and ongoing dissociative experiences, would be highly unlikely to spontaneously resolve without any sort of interventional treatment. So we can further hypothesize that DID prevalence would be fairly consistent across different age groups, including older adults. This assumes, of course, that DID has no impact on life expectancy, which is something we need to consider. And we must remember that serious mental illness does have an impact, with the World Health Organization estimating that people with serious mental illnesses have a 10 to 25-year reduction in life expectancy. This health inequality is not simply explicable due to differences in suicide rates, but rather due to people with serious mental illnesses being at greater risk of poor physical health, the reasons of which being multifactorial. So let's think about the older adult. If we take the term older adult to mean person over the age of 65, we're talking about those born between 1920 and 1956, and slightly prior to this for our rare centenarians. However, for ease, let's mainly think about those aged 65 to 85, so born between 1935 and 1956, and who became adults between 1953 and 1974. These individuals were born either slightly prior, during, or shortly after the Second World War, the impact of which would have been felt on a societal level differently in each country. Consider also the impact of other international conflicts, going on during these individuals' formative years, such as the Cold War, Korean War, and Vietnam War, to name just a few, as well as the huge societal shifts occurring in this time, including the changing status of women. These societal contexts, which will differ across the globe, have specific impacts on different generations. But when we think about mental health problems, we have to consider the age of manifestation of these difficulties and the cultural context of the time on both a societal level and in terms of psychiatric practice. Although we know that DID is a disorder which begins in childhood, if we return to the suggestion that the mean age of diagnosis of DID is between the ages of 28 to 35, and take age 30 as an example, we can see that our current 65 to 85-year-olds would have been 30 between 1965 and 1986. We need to consider how individuals presenting to services during this time period would likely to have been assessed, the level of professional awareness of DID, psychiatric treatments available, and access to mental health services across the population, all of which will vary from country to country. This is important because thinking in this way, we can better understand historical diagnosis in our older adults. Important to take a detailed history wherever possible and review medical records if available. Having the benefit of being able to see the course of illness in an older adult and review a historical diagnosis with the benefit of hindsight can lead us to think differently about those diagnoses acquired by a patient 20, 30, 40, 50, or even 60 years ago. A patient with a diagnosis of DID, or in the case of those in services prior to 1994, multiple personality disorder, is rarely encountered by the practicing clinician. But hopefully I've led you to consider that this may not be reflective of the true prevalence of DID. Given the functional difficulties often experienced by patients with DID, it seems unlikely that an older adult with this diagnosis would have evaded services for a lifetime before presenting first in old age. Although this is always a possibility, as in such a situation, you may be witnessing a decline in previous coping mechanisms due to aging, loss, and/or comorbid cognitive decline. But perhaps more likely they are known to services already and have received a different label. Here are some of the differential diagnoses which could have been acquired by patients instead of a diagnosis of DID. So we have other dissociative disorders, PTSD, borderline personality disorder, psychosis, substance misuse, and major depressive disorder, to name a few. And these, of course, can represent true psychiatric comorbidity, so may well be appropriate diagnoses for your patient. But miss that DID underpins the comorbid illness and may well make those psychiatric comorbidities difficult to treat. Again, it is easy to miss DID when focusing on identifying multiple personalities rather than periods of dissociation and PTSD type symptoms, which are likely to be more prominent. Inquiry about dissociative symptoms can be less extensive in comparison to psychotic and affective symptoms. But before we move on to talk about aging itself and how it may impact on DID, it is important to draw focus on the impact of stigma when it comes to older adults and mental health. Mental illness remains hugely stigmatized worldwide, and although steps have been taken internationally to try and reduce this, it nonetheless remains an additional burden on individuals suffering from mental health problems. Stigma can be magnified by an individual's cultural background or for those with intersectional characteristics. Stigma continues to prevent patients accessing the help they need, and in older adults may have led to a lifetime of masking symptoms and difficulties. Indeed, the general public may be more conscious of hearing voices as a symptom of madness, and in the context of DID, therefore be more willing to speak to a professional about troublesome lapses in time or other descriptions of dissociative symptoms, then disclose that they can hear a child's voice in their head or other similar experiences of alters. But clearly, there is more to being an older adult than increased duration of illness, increased potential time in services, and exposure to psychosocial factors specific to their generation. We have the impact of aging itself. I'm going to briefly talk about psychosocial models of aging, but please consider this in the context of increased physical frailty and physical illness comorbidity. You may be familiar with Erikson's stages of psychosocial development from the 1950s. Erik Erikson was a psychoanalyst who came up with these stages in collaboration with his wife, Joan Erikson, who was a teacher and who is often left uncredited. This theory suggests that each life stage has an aspect to be negotiated by the individual, with the balance tipping towards a more positive of the dichotomy. For example, leave the stage of infancy with more trust and mistrust. If this is successful, then the individual develops the virtue for that life stage. Without the development of these virtues, Erikson suggested that problems may develop later in life. The theory believes it's possible to modify the outcome of these developmental stages later in life, though. In old age, the development of a sense of existential identity is important to help the individual withstand the physical disintegration and feel their life had purpose and meaning. To accept their life as it has unfolded, assuming responsibility for both the good and aspects of one's life, this leads to the sense of fulfillment and wisdom. Drawing on the virtues from the previous stages can help an individual to achieve this. The alternative in old age is deep feelings of resentment, regret, and despair. In DID, we need to consider diachronic disunity, a feeling of alienation from one's past. This may be experienced by the main personality, who we might consider the patient, or by one or more other alters within the system. If we accept anything from Erikson's model of aging, old age may be especially difficult for patients with DID to navigate. There are several other different models of aging. Some of the most renowned are activity theory by Havighurst, which suggests that successful aging is related to ongoing mental and physical activity. The theory behind this is that an individual's sense of self is tied to their roles within society. Disengagement theory by Cumming et al. Looks at aging from a sociological perspective, how the disengagement of the individual from society and society from the individual is mutually beneficial. Through this disengagement, the individual has increasing time for introspection, which the theory considers helps increase life satisfaction. Another theory is the 4 stages of maturity by Cohen, which can be considered as an extension of Erikson's theory. It divides old age into 4 stages, which the individual goes through a process of evaluating and accepting their life, whilst retaining a sense of feeling needed by society. And the final theory I'll draw your attention to is life course perspective by Elder, which essentially suggests that social factors early in life have an impact on later life. For instance, childhood poverty would increase an older adult's risk of poverty. Hopefully, by briefly touching on these theories, you can see how mental illness would be a negative modifying factor in an individual's ability to age psychologically successfully. Patients with DID report increased sense of alienation, isolation, and loneliness. This is important to be aware of, as loneliness is a significant problem for the older adult. On this slide, I have some statistics from the UK. Research from a 2016 to 2017 population survey found that 5 to 16% of the older population reported feeling lonely, with 10% of those over 65 feeling lonely most or all of the time. The survey looked at all adults, but was able to generate a specific profile for the older adults, namely a widowed homeowner living alone with long-term health conditions. We know that loneliness has a negative impact on all aspects of health, and there is a clear link between loneliness and suicide, which is a separate talk in itself. The Bangor longitudinal study of aging, which took place between 1975 and 1999, highlights that loneliness is not the same as social isolation. After all, it is possible to be lonely in a crowd. So given this, we need to consider again that older adults with DID may be at increased risk of loneliness compared to the general population. Other hypotheses we can make in the aging individual with DID is previously mentioned increased risk of diachronic disunity, which may make navigating the psychological process of aging more difficult. Alters need to be considered too. Alters can age or not, and if they age, they can age chronologically or otherwise, or in some cases can age slide. So in DID, you need to consider the impact of aging on several different individuals within the system. It is also important to continue to be aware of the impact of childhood trauma. Several triggers could emerge later in life, such as the death of an abuser, family members reaching age of abuse, but patient having less control over safeguarding their situation in the case of grandchildren living elsewhere. Also, increased dependency on care from others may be triggering, particularly if this includes personal care. And of course, we must be mindful of the risk of elder abuse in all older adults, and how experience of this not only is hugely damaging in itself, but could trigger previous traumatic memories. And lastly, the impact of organic illness. The risk of dementia increases as we age, and in patients with DID, this may impact on previous coping mechanisms and ways in which they have come to manage their system. A systemic organic illness will impact on all alters, but clearly may impact differently depending on whether an alter holds longer-term memories or whether they serve a more day-to-day function. We can hypothesize on whether dementia would cause disintegration and consider whether DID symptoms could be mistaken for psychosis in such individuals. To conclude, I hope this talk has given you much food for thought and will trigger some healthy professional discussion. I hope I've invited you to consider the possibility of undiagnosed DID in older adults, in your older adult caseload, and lead you to consider the increased psychological burden of aging in DID patients. Of course, much more research is needed in this area, and a longitudinal study of our younger DID patients as they navigate the life stages and age would be a fantastic starting point. Here are some of the references, and thank you very much for your time and for listening today.